Kia ora everyone and welcome to this Goodfellow webinar on assessment of capacity. My name is Dr. Grace Lee. I'm a general practitioner and I'll be moderating this session. Tonight I have the pleasure of introducing three fabulous speakers. We have barrister Alison Douglas, who will be talking, Dr. Greg Young, a psychiatrist, and to talk about ethics, Professor John McMillan. Now I'll be handing the presentation over to Alison.
Kia ora tātou. Thank you very much. It's my task to begin our presentation, bringing together, hopefully, law, medicine and ethics in terms of looking at mental capacity law and practice. So just as an overview, the way that we want to present the seminar is for me to introduce you to some of the key legal concepts and the legal framework that we're working within. Then I'll hand over to John, who will discuss the ethics and present a case, which we refer to in our book. And then finally, of course, Greg will then pick up and do focus on the how-to of mental capacity. So why is capacity important? Capacity is really important because it refers to a person's functional ability to make decisions. And the consequences that if you're found not to have capacity means that other people will make decisions. So whether your decisions are valid, and that can be in a legal sense, and if not, then other people will decide. And it raises questions about who should be appointed to decide for you, a proxy decision maker or some kind of substitute decision maker. We make a distinction also between legal capacity and mental capacity. And when we're talking about a capacity assessment, we're really in the realm of looking at what is the person's mental ability to understand, use or weigh and retain information and or communicate that information. But we apply a legal test. So it is a socio-legal construct in that sense. And I should say, not to confuse, we use the terms capacity and competence interchangeably as they are in the law as well. So then the two main points here, well, the two key concepts to think of is, first of all, capacity itself, which is the legal bright line that determines whether there should be intervention in a person's life. And then secondly, when decisions are made by others, the standard for decision making is called best interest. And that's when others will make a decision. And there's been a shift in thinking in and around medical law and mental capacity law, from the view moving perhaps from what the doctors think best, in simple terms, to the patient's point of view. So there's been a shift in the legal cases and the thinking around best interest.
Okay, well, shall I start talking and see if you can maybe move to your phone? That might be a bit better. So the final point that Alison made on this slide was she was talking about best interests and capacity assessment mattering because it's a legal bright line. Is important legally and clinically and ethically, because what this is ultimately all about is a judgment that determines whether or not someone has the right to make some decisions for themselves. And what's been happening in the law and internationally, particularly following the Convention for the Rights of the CRPD, is that there's a growing emphasis upon supported decision making as being the first step in capacity assessment, rather than moving towards assessing whether or not the person meets this bright line test. That's the point that she was making then. Okay, so capacity, and this is something that we talk about at some length in the book, and it was not something that I was immediately aware of till I started working on this project, as we're all familiar with the idea of capacities being important for informed consent. So consent counts as a valid informed consent when it's informed, voluntary and made with capacity. But there are actually a whole bunch of different contexts in which capacity can be called into question and needs to be assessed. So the capacity to make a will, enter into a contract, some of the abilities required to do that will have things in common with the decision to give consent to a treatment, to make and revoke an enduring power of attorney. There may be similar decision-making abilities required there, or there may be some variations. The one that quite a lot of attention is being paid to now, and I suspect the one that GPs will have input into, it's the case that I will talk about in a moment, is when somebody's living arrangements are going to be changed and they're going to be placed into supported care. This capacity can need to be assessed for whether someone has the capacity to take part in court proceedings. There's some interesting case law and really complex and quite fascinating cases on whether or not people have the capacity to marry and enter into new sexual relationships. So there's quite an influential UK case where there was a gentleman of advanced years who seemed to be acting out of character according to his children and wanted to marry a younger woman and redo his will. And so his capacity to consent to that and make those decisions was called into question. Greg may talk about this last one later on, substance addiction treatment, the SAC Act. So there's a relatively new bit of legislation in New Zealand which has a capacity test built into it. So it's an example of how the law is firming up. Alison's not here yet. Greg, I haven't seen anything outrageously unlawful yet.
It all sounds good, John.
Good. I'll keep going. So in terms of the New Zealand legal context, and this is the case in Australia and England as well, is if somebody is over the age of consent, there's a thing called the presumption of capacity. So all adult patients should be presumed to have capacity to consent to medical treatment and in other domains, unless something happens that gives you reason to question whether or not that person has retained their capacity. And then it's at that point that you might think about, well, do I need to assess this? This is kind of fairly important, and it's interestingly different from what happens with mature minors, for example. So in the case of children under the age of 16, if it's not for termination of pregnancy or contraception, we tend to presume that they don't have capacity unless we have reasons for thinking that they are in fact a mature minor. Capacity is decision and time specific. So a number of people will have conditions which fluctuate, and so what we would try to do is find out what it is that they want at a time when they're able to express with as much capacity or decision-making ability as they can what it is that they want to happen to them. Capacity is also decision or task specific. So as I mentioned on the previous slide, there's a bunch of different things that we might be judged to have capacity or lack capacity for. So that's one reason for thinking of it as a task specific notion. But it's also because if we think about within so the context of caring for someone who has dementia, which is progressing, what we'd be trying to do is enhance the number of decisions that this person can continue to take for themselves. And so we would only be thinking about, does someone else need to make this decision for them when the nature of the decision is such that it's particularly challenging or particularly significant. So capacity is generally viewed to be decision and task specific as well as time specific. Almost all of the tests will relate to functional abilities that people have. There's some variation in jurisdictions between it, but in New Zealand it looks like the Mental Capacity Act test is bedding down as the one that we should use, the English and Welsh test from 2005. And it emphasises the ability to be able to understand, retain, use away in the balance, and communicate a decision. Another principle that's important in revisionary mental health law is this idea of the least restrictive intervention and maximising participation. So I've already mentioned the CRPD idea that the emphasis is on enhancing people's ability to make their own decisions, supported decision making. Another important legal principle is that whatever happens once we've made a judgment that someone else needs to help this person out with this decision, is that whatever thing is decided on should be the least restrictive intervention in terms of what it means for that person's liberty. As you'll know, if you're an adult, you've got the right to make unwise, imprudent, or completely foolish decisions with respect to your medical treatment from a legal point of view. And so when it comes to the assessment of capacity, it's therefore important that what's looked at is not the nature of the reasons that someone's acting on for this particular decision. It's the decision-making abilities that they have in fact have. So it sounds a little bit confusing at first, but the legal position is that capacity tests the decision-making abilities that a person has, but it doesn't have to be the case that they use them. So you could be Einstein or someone completely brilliant. If you are, you'd be judged to have capacity, but even if you still have the right to make a foolish or very unwise decision. And that's kind of, that can be counterintuitive. And I think clinically, actually, when someone isn't thinking through something through well, then from a clinical and ethical point of view, you're thinking, well, that's not really a competent decision. So this is the way that the law views these things anyway. Mental disability is not the same as legal capacity. So again, so one of the other big legal pushes here is that there shouldn't be a necessary connection between a mental disability or a mental illness and somebody lacking capacity. They're viewed as being separate kinds of assessment. So one of the other things that puts a different take, a different slant on capacity assessment in New Zealand is the importance of tikanga Māori and cultural diversity. The law tends to view patients and individuals as being individuals with rights, and capacity determines whether or not they have these rights in a particular situation. And for many people in New Zealand, in particular for Māori, decision making is often with whānau and a kind of broader set of people involved. So one of the ways in which capacity needs to be approached in New Zealand is to be kind of mindful of that context, engagement with patients. And I don't know. I think if I'd looked at these slides before, I might try to pronounce that word. Oh, whakawhanagatanga. Yeah, I do know that.
I was just thinking that John is doing such a brilliant job. I now feel redundant. So this is, of course, what we're aiming for. Can I just say that this is a very multidisciplinary exercise, and just as lawyers and ethicists need, clinical literacy and understanding about what goes on in medicine, just so too do, doctors and ethicists also, need to understand the law and have the legal literacy. So we're working hard on that tonight.
Great.
All right, shall I keep going then? And I feel free, John, to interrupt me as we go. So we're talking now about, we've moved to the slide on consent to healthcare. So moving on from the concepts that John has taken you through, there are two main laws that apply to this area of mental capacity law. And of course, the first is in the Health and Disability Commissioner Code of Patients' Rights. And so the basic ability to consent to healthcare and or make a choice, which includes refusing healthcare, forms the basis in this area of law, of course. And we're thinking now about rights 5, 6, and 7 of the Code of Patients' Rights. And if we take this all back to the basics of what is consent in this context, there's three main elements. I mean, the first is having effective communication. The second is, of course, sufficient information. And then the third is having capacity or competence to consent. In fact, we three have actually kind of added a fourth element, which is the ability to deliberate. And so, you know, relative to the decision to be made and taking into account all the practical realities, having the opportunity to think about something and actually reason and make a decision. Sometimes time is a factor in informed consent. So the code itself doesn't, in fact, define capacity, and it actually talks about it as competence. And as I say, we use those terms interchangeably. But it does recognise those important principles, including the presumption of capacity, and also that people with diminished competence or capacity have a right to participate in decisions to the level that they are able. And that is expressly recognised. And another important right under right 7.4, of course, is that where a person does lack capacity and a decision needs to be made, the doctor or the provider can make that decision if it's necessary and in that person's best interests. And there's quite a bit of talk about how right 7.4 applies and when we should use it and how long we should use it for. But those are the important parts in and around right 7. But all of those rights, 5, 6 and 7, and of course the umbrella rights, the more aspirational rights, such as the right to respect and dignity, all fit into how we view capacity. All right, so the other main law, we're moving on now, is the PPPR Act, the Protection of Personal and Property Rights Act. That's a law that's been around for quite a while, and I say that it has good bones in the sense that it is in fact quite human rights based, and it was put in at a time when there was quite a lot of murkiness in and around how we viewed mental health law or compulsory treatment laws. But it came into play in 1988, and it is in need of review. But the basics and the concepts are also in that act, which is really designed as an adult guardianship law. So when lack of capacity is established, then the law can intervene. And the two main areas apply, first of all, for enduring powers of attorney. So when a person is mentally capable, they can make a power of attorney and put someone else in their shoes to make decisions on their behalf if they later lack capacity. And the second area, of course, is the court orders that can be obtained. Now, it's overly complex law, and it is going to be reviewed by the Law Commission. So that's a watch this space. But that is often the source of a referral to a GP or someone who's undertaking a capacity assessment, because someone might need to activate an enduring power of attorney, or the court may be looking at appointing a welfare guardian. And in those circumstances, a capacity assessment will be undertaken. And then John's already mentioned the Convention on the Rights of Persons with Disabilities, and this has really sort of have come into play. New Zealand ratified it in 2008, and we're still to work out exactly how it's going to be embedded in our domestic law. But the real principles there are in and around supported decision making. And so there is a role in capacity assessments in supporting the person as much as possible to make the decision for themselves, or looking at what kinds of supports they might need to put them in a place that will allow them to make decisions. Turning on then to the presumption of capacity, this is what, in fact, John should be speaking to this slide, because this is what he says is about making the case. So when you're presented with a medical certificate or a form such as this, it might be familiar to some. It floats around the family court, and it's used in support of applications under the PPPR Act. The doctor or the assessor is being asked to assess capacity, and if they find that the person lacks capacity, then the key point is that they need to give reasons why that is so. And that's why we say it's about making the case, because if the starting point is a presumption of capacity, then if that's going to be overturned based on a capacity assessment, then we need to have good reasons. So you'll see there highlighted question 5 on that form as it happens. And I always say that it's not a tick the box exercise. So if you say the person totally or wholly lacks capacity, you need to say why. And you can squeeze it in on that form, or you can write a separate letter. But what the lawyer or the judge or the person seeking the referral to you is looking for is the reasons that you have assessed that the person lacks capacity. So that's an important point. And of course, the presumption of capacity doesn't mean that we don't take any steps at all, because there will often be reasons why there will be red flags or triggers to look at whether the person is impaired in terms of decision making. So then moving on. Oh, John, are you there?
Next slide, thanks, John. Cheers.
Oh. So one thing to come away with this Mental Capacity Law 101 is to understand this core legal test. You'll remember that when when we showed you the PPPR Act slide, I said that it was way too complex, and it is. It has a number of different thresholds or legal tests, usually in and around understanding and foreseeing the consequences of decisions. And what we've done in the toolkit is to use the Mental Capacity Act that is in the UK for England and Wales, and build that into a core legal test, the core functional test. And so we say that this is a simpler and a clearer way of applying and looking at assessing the person's abilities. So the first one, of course, is whether the person understands the information that's been given to them. And that, of course, has to be the relevant information. Secondly, the principle is that of whether the person can retain the information at least long enough to make a decision. Thirdly, if you go on to number 3, is that whether the person can use or weigh the information as part of making a decision. And that's the reasoning ability and appreciating the decision. So it's about the ability to weigh up options. So if you are familiar with the PPPR Act, you often see that in the legal test there as whether the person can understand and foresee the consequences of their decision making. So they're regarded in law as parallel, similar tests. And finally, of course, the person has to have the ability to communicate the decision in some way. And just to note at the bottom of that slide is that already New Zealand has used this core functional test, first of all in the Substance Addiction Compulsory Treatment Act, known to those of us as the SACCAT. It's a similar law to the Mental Health Act, but it is for people with severe substance addiction. And if they are unable to consent to their treatment for substance addiction, that is a criterion now in that act for compulsory treatment. And of course, when we all go to the polls in the referendum on the End of Life Choice Act, the same core legal test has been included. So it is creeping into our law, and it is a useful, simple approach to understand those 4 elements of the core test. So just briefly, just to make the point that the development in the English law in particular has been to really carefully look at those 4 elements. And there have been a number of decisions in their court, the Court of Protection, where they've emphasised it's really important that the person who's being assessed does have the relevant information, and that they shouldn't be put in a position of trying to make decisions or demonstrating, as it were, their ability to make decisions if they aren't actually given the full information to weigh up the information. So it is said that they shouldn't start with a blank canvas. And interestingly, the judge in this case, which was a classic case of a woman not wishing to, having been hospitalised, not wishing to stay in residential care and wanting to live in her own home. And she was in fact found to have capacity, mainly on the point that she wasn't properly given the options about the decisions that needed to be made about her living arrangements. But the judge there emphasised that it is important that professionals, including judges, I might add, should look carefully at capacity assessments when they look at a best interest analysis and avoid what they call the protection imperative. It's very easy for us want to do what we think is in the person's best interest, than perhaps standing back and thinking, in this person's set of values, their framework for looking at decisions and how they're going about it. That's really what we're trying to do, look at their decision-making ability. And not to jump, it's very easy to jump into, well, what I think is the assessor might be in that person's best interests. So, all right. And then finally, just about referrals. Really, all health professionals should be involved with assessing capacity. And if you think about it, informed consent or obtaining consent from a patient is within every doctor's scope of practice. So even at the level of capacity to consent to healthcare, it is a skill that we're all required to have. And although often these assessments are done intuitively, what we're going to show you in the next part is that there is a need to give some transparency and robustness in a way as to how we go about doing those assessments, especially when there are more significant decisions and there are consequences for the person who's being assessed. This is an important point, of course, for lawyers who will be often approaching a GP or a doctor to get a capacity assessment for a whole range of decisions that might be relevant to their client. And I'm happy to answer some questions further down the track in and around that. But really the point is there needs to be quite a collaborative effort when we're in the situation of seeking a formal capacity assessment and there's a lawyer briefing a doctor or asking the doctor for an assessment. And so you as the doctor also need to be asking the right questions and making sure that the referrer is giving you the information that you need to do the capacity assessment. All right, so I'll sign off at this point and hand over to John.
Now, Alison, just before we do that, it's probably a good time just to ask some quick questions before we move over to John. Now, those of us in the audience, as you mentioned before, we have varying levels of understanding of legal terms. So just quickly, if you could iterate to us what the bright line test means.
Sure. Well, I made that one up, of course, as you do. But what the bright line test means is that the way the law regards capacity is that if you have capacity, then you can make decisions for yourself. But if you lack capacity and you're on the other side of that bright line, then a substitute decision maker will be appointed or other people will make decisions on your behalf. So that's the intention of the bright line. I suppose what the CRPD and the human rights focus has done is to say, well, really there is a spectrum there, that really the point is to support people and the levels of support may increase as they cross the bright line in law. And so some people will need 100% support. But to think about it as across a spectrum. But the way, unfortunately, the law has a very square box, sort of blunt instrument approach. And so you either have capacity to make decisions or you're on the other side, and you lack capacity to make decisions.
Okay. And you mentioned as a part of the, I guess, the testing framework for assessing capacity, you mentioned retention of information. How long do they need to be able to retain information in order to have be competent in capacity?
Sure. Greg might well be able to build this into his discussion, but the element of retain, or the ability to retain information, is really around retaining information for long enough to work through that person's reasoning ability. So it might mean that they still have short-term memory loss and they have early onset of dementia or whatever, but for that, if the assessor is able to take them through the scenario, work through those elements, and they can retain the information for long enough to reach a decision, that is usually sufficient. It is the element of retain. It doesn't actually appear in the PPPR Act or strictly in our law, but it does have some application, and Greg will be able to sort of mention that also when he deals with assessment.
Okay. Are nurse practitioners able, in the law's eyes, do they have the ability to also assess capacity?
What a great question. Yes, well, of course, they too are health practitioners, and who, within their scope of practice for consent to the procedures and things that they get involved with, are, of course, doing capacity assessments on one level. They may not be doing formal capacity assessments that go to court, but of course, I think it is very, very important that we move on and have nurses involved in capacity assessment. And of course, often, particularly in the sort of psychogeriatric situation, there's usually a team approach in terms of nurses being involved in an assessment and drawing together the relevant information. So that's another aspect, but I think there is a real need. Under the PPPR Act, I think mental health nurses nursing is recognised, but probably not as much as it should be, I would say. And of course, psychologists are recognised, particularly for reports for the court as well.
Okay, we do have lots of questions here, but it's probably a good time to move on, just to move through the pacing. So, John, if you would like to show us your case and work through some of the slides that you'll be talking to us today about.
So, Mrs. H is a case that we discuss in the first chapter of the book, and it's a situation that Greg became involved in. He was called in to assist in assessing the capacity of Mrs. H, and it's quite it raises kind of a number of the difficult underpinning ethical tensions that can occur in capacity assessment, particularly around decisions about where somebody is going to live and the decision about them going into supported living. So Mrs. H is a 75-year-old Pākehā widow who has lived alone for 18 years. Her husband died many years earlier. She's estranged from her children, and she has no other family she keeps to herself and does not have visitors. She has always been fiercely independent and has been described as eccentric because of her unusual ideas about spirituality, diet, and alternative medicine. In the past, she has been extremely reluctant to accept home help or formal support, even when strongly urged to do so by her GP and hospital clinicians. She has a number of medical conditions, including type 2 diabetes, a severe spinal deformity that impairs her mobility, macular degeneration with significant visual impairment, and she has had a number of small strokes. In the past, she has fallen and suffered a fractured neck of femur, and on that occasion, she lay undetected for 2 days. She attends her GP for follow-up, but she is very resistant to the GP's advice on any matter, preferring to treat herself with an idiosyncratic vegetarian type diet and homeopathic remedies. 2 months ago, Mrs. H was admitted to hospital after a fall for the 3rd time in the previous 12 months. On this occasion, the ambulance was called by a concerned neighbour. The admitting doctor noted that she was semi-conscious, confused, dehydrated, underweight, and she had what appeared to be a recent pressured ulcer on her buttock. So this is a situation where there's someone who has a kind of set of values which are consistent with how it is that she wants to continue living now. Her condition is deteriorating. those around her, her GP, social workers and others, are becoming very concerned for her well-being. And so one of the things that we tease out of this case is, well, what are the underlying ethical principles or tensions and conflict here? And there are different ways of trying to do that. The way that we chose to do it was to pick these three things out as underpinning principles. Now, we're all kind of familiar with the idea that autonomy and respect for persons is important when thinking about ethics, but we decided to go for liberty as a way to articulate what's often in tension in this kind of situation. And it relates to what Alison was talking about before, about how capacity functions as a bright line or a threshold, above which you have the right to make decisions and below which you lose some liberties. So one of the underpinning ethical principles in here is maximising people's liberties to do things and not overriding people's liberties unless we've got a kind of particularly good reason to do that. We thought that the idea of well-being captured both issues around health and how well she's living and the possibility of future falls for her, but also her conception of what it is to live well, which is without a lot of assistance from traditional medicine and with her own diet and these sorts of values. So these things are in tension here. What we added, which isn't a feature of some of the other ethical discussions in capacity assessment, is an idea that I think is familiar to all GPs and all doctors, the kind of old traditional idea of first of all, do no harm. Because in many cases, and it could well be the case with Mrs. H, you can have kind of grave concerns about her well-being and her ability to kind of think through what's in her interests. But it's unless it's the case that there's something that you can do that's going to make the situation better and isn't just going to make it worse, then it may be better to not interfere. And that's often a feature of capacity assessment, even in situations where you think someone's decision-making ability about this is quite disturbed. It might be the case that there's not much that you can do that's going to make the situation better, so it's better to not act. I was going to talk about this consent and refusal asymmetry problem as well, but I'm conscious of the time, so I might just park this so there's enough time for Greg to speak. So I might hand over to you now, Greg.
The way we got started in all of this was through being asked to do teaching sessions, firstly in the hospitals. I was working at Hutt Hospital, and other doctors wanted me to come along and do capacity assessments and then teach them how to do capacity assessments. And then Alice and I teamed up, and then John joined us, and we've been teaching people a way of doing it. So we can't answer every single capacity. There have been a lot of interesting questions come through about scenarios, and it's difficult to know exactly in those scenarios what we think about capacity. But what we're proposing is a framework for how you might approach deciding whether you make the case that the person has capacity or doesn't have capacity for a particular decision. We came up with a toolkit, which is a core module, if you like, and all those different kinds of decisions are really just iterations of the core module into the different scenarios. I think we've already covered a slide that deals with all the specific points on this particular few focus points. The starting point for a capacity assessment is, is it needed, and why would it be needed? So you presume people have capacity, but if people develop dementia, and let's just take the common scenario of the older person, the older patient, developing cognitive problems, even that person, you'd say, starts off with a presumption of capacity. So there's a condition that might progress and lead to incapacity. We know this, but we don't start off by saying they lack capacity. We start off by saying they have capacity. And then as decisions become progressively more difficult, or they become progressively more impaired, we start to worry more. So we want to know, if you get asked to do a capacity assessment, I would suggest the first question you'd say is, well, why are you worried about it? What's happened that makes this a problem now? And then there's something about the decision. So it may be a really serious decision. So a strange decision about a will where there's a lot of money involved, maybe something you don't actually want to do the assessment of, but you might see the value of capacity assessment being done by somebody in that situation. More commonly, I think the scenario we're focusing on tonight is moving into age residential care. And you might have a lot of information about a person in that situation. You may have gone through a few iterations trying to support the person, so you have a good sense of what should happen and how the person is thinking about it. Another red flag we call this for assessing capacity, for worrying about a person's capacity, is if they make a decision that's completely out of character for them. And then you'd expect a family member to come along and say, hey, look, this just isn't the way they normally decide this. There was a question about sexual relationships. Without diving into that particular topic at the moment, it may be that sort of question, is this in character or out of character for this person, becomes relevant for that scenario. So that's a list of what these decisions may be about. Just to sort of, the history of that actually is that back in the 50s, when psychiatric hospitals in America were full and starting to be, people starting to be discharged, there was a view that if you'd been under the Mental Health Act, a committed patient, you couldn't make decisions. And quickly, everybody realized that, in fact, you'd been committed because you had delusions about a particular thing and hallucinations, and maybe got agitated and disturbed, didn't mean you couldn't get married, or didn't mean you couldn't, have a taxi business or buy a house later on. So they realized that it was much fairer on people to just look at what it was they were trying to decide and then see if they could make that decision on its merits. I just want to make a point that came up in some questions earlier on, that this talk tonight is really about elective decisions, so it's relatively unhurried decisions, and it's not about compulsory Mental Health Act treatment. So this isn't about the Mental Health Act, it's not about committing people. I know there was a question about that. There perhaps should be a separate webinar on which act, but that's not what we'll talk about tonight. So the definition of capacity that we're using is that 4-point definition: understand, retain, use and weigh, and communicate. Just so that you are not put out by it, the definition in the PPPR Act, so actually written in law, is this. The person understands the nature of decisions, so that fits in with understand, or sees the consequences of decisions or any failure to make decisions. And we would say that sort of is still part of understanding the decision, but also brings in the idea of thinking about the options, I suppose. Communicate decisions. As Alison said, retain doesn't actually come to the 3PR Act definition. And it excludes ordinary imprudence. People can do things that you might think are unwise if they have capacity to make that decision. And it's not just because the person is subject to compulsory treatment under the Mental Health Act. I might just answer the question on retain now. It's the second point on this slide before ability, so understand the information relevant to the decision. Retain the information for the appropriate time. So going back to what I said at the beginning, this is a framework where you're facing a patient who you've been told, they have developing dementia. You're concerned about their losing their abilities to make decisions. You've been worried maybe for some time, or you have history to say that you could be worried about that. And now there's some important thing to be decided. And you could see the person perhaps is struggling to make that decision and there's a disastrous consequence. So memory loss is their symptom, right? They've got Alzheimer's disease. Memory loss is a cardinal symptom. Is it important or not? Well, it may be or may not be. So they don't have to retain the information for X amount of time. But if they can't retain the information for any time at all, they sit down and they say, yep, I want to go into residential care because, you told me it's a good thing to do. And then within minutes, they've completely forgot what you talked about. You'd have to worry that suggests they don't really grasp what you're doing. They're going to leave the room and they're going to think they're going home. They're not going to think something's changed. They've forgotten it. Or if they change their mind one day to the next and don't remember that they've changed, don't have a reason for changing their mind, then retaining becomes an issue. So it's there as part of the framework, and you may want to when you make your case that the person lacks capacity because there's a dangerous decision, when you see that that's an issue, you can base the case on I'm sorry, I'll just go back one, John, because using and weighing so using and weighing is the reasoning process. And again, the question of delusions came up. That's a really interesting question, and probably also not something to dive into as an ordinary sort of case. But when somebody has reasons for what they want to do, they'll have values, and their values may be very foreign to your values, but shared by other people, so they don't amount to delusions, or they may be completely idiosyncratic and therefore sound like delusions, and they may be delusions. And I guess your job is to think about, are they able to say, well, this is really important to me, but if you say I'm going to die, then I've changed my mind. So how do they use that information? How do they weigh it in the balance with other information? Do they not give it any value, or do they give it all the value and they don't listen to anything you're saying? And does that amount to something that you would say in your letter to the court suggests they lack the capacity? One last comment on this slide. If any of you look at Grisso and Applebaum, those are famous names in capacity assessment, an American system of assessing capacity, they talk about appreciate. So we put that under understand. And appreciate means that does the person realize that the information we're talking about, the decision we're talking about, the consequences we're talking about actually applies to the person themselves. So appreciate fits into their understanding the information relevant to the decision. Thanks, John. So in the case of somebody like Mrs. H, you're going to find, we're talking about somebody who has dementia, we're talking about somebody where there's been a red flag put up about how they're making decisions, and now there's an important decision to make. You're probably going to find there's a problem. You can't presuppose beforehand that they have capacity or don't, but that's the bright line. You have to when you do the assessment, you have to make a call. Does this amount to incapacity? Does whatever problems you find amount to incapacity, or does it not? Otherwise, if they don't have incapacity, you can't go to court and ask the judge to do anything. An interesting grey zone is a person who can be scaffolded into a decision, and in Māori people, that's family will do that, and maybe there's almost no need for this kind of act because the family will look after the person and they'll get to a decision because they trust the family and it works well. Other cultures too. Gary Chung, who helped us in the writing up, pointed this out. The law is written around a very individualistic way of making decisions. So that's why it's a grey zone. It's not because it really is a grey zone in human life. It's because the way the law is written, you've got to say yes or no, and it's about the person. I've had various slides over the years showing folly, and that's just a slide showing folly. I believe a high number of base jumpers die, and so, but I presume those people have capacity. They've got all the suits on, they know what they're doing, and they've been wearing helmets and a camera, so they know exactly what's going on, and they presumably have capacity to do that suicidal behaviour. Now, we did some research into what GPs think, what all doctors actually think about capacity assessments, and a lot of concern about feeling you don't know what questions to ask. It's a tricky kind of assessment to do. We propose that the assessment should be done in 3 phases. That when you hear about somebody coming to see you for capacity assessment, it shouldn't be as they walk into your room, because then you're going to have a hard time. You may need to somehow have a system of getting a conversation before that assessment interview, the assessment appointment, where you can work out what you need to know for the assessment. So has everything been done to support the person down as Mrs. H? What has happened before we get to this point of having to go to court and fight with her over what she wants to do? In your patients, you may know this already, or you may need to have this put to you. Do you have a clear idea of the present situation? So one of the things that I find quite difficult is I get asked to do capacity assessments for legal situations, and I say to the lawyers, you need to write me a letter and tell me what it is, what's the decision, and what are the problems with it, why do you think it's an issue? And I think in general practice you need the same thing. If a lawyer wants you to do some sort of assessment, or the family wants you to do an assessment of capacity for example, going to age residential care, you can't do that without having a really clear idea, ideally written down, about what the problems are. When it comes to doing the assessment, do you need anybody there who can help you? There was a question about a translator. Should the family translate? I couldn't read all the details of the question. It was quite a complex question, but it was a good question because, who is the best person to be in the room? We know that sometimes families can be partisan, and you may not feel comfortable with that. If it's a big decision, a contentious decision, and there's resourcing for it, then having an interpreter, professional interpreter present is probably better. Obviously, knowing the decision and what the alternatives are is vital. This was relevant for me when I was working in consult liaison psychiatry, and surgeons would say, "Come and check the capacity for this person." I don't think they're refusing surgery, but it doesn't make sense. And I'd really enjoy what the alternatives are and what the risks and benefits are. So I felt that really a joint assessment was necessary in that situation, where I'd get the surgical registrar, because the surgeon's too busy or whatever. The surgical registrar come in and can talk through the options, the surgical options. And I'd be listening to how the person remembered the options, understood the options, and how they thought about their own preference. So my contribution was just the process thing, because I don't know the surgical options. Asking the patient for their reasons is getting to that reasoning that they're using and weighing information, and it gets into delusions, and it gets into cultural things as well, personal things and cultural things, where people have reasons which they can often articulate as to why they do something that may be different to what you'd expect, and they'd be perfectly good reasons. You just need to know what they are. Is there any room for negotiation? So that's sort of, if you gave new information, would the person change their mind? Cases of Mrs. H, the question I asked her was, if you would afford a game, and you would allow on the ground again for a few days, would that be enough to change your mind? Thanks. All right, so this actually, to be fair, isn't Mrs. H's. It's another case. We don't have time for the second case, but this is the kind of way houses get, and it's just such a striking. This was actually taken by a neighbour who was campaigning to buy this old man's house. So the photograph was taken and given to me with malicious intent, as I found out later. But it's a great photo because it shows a swallow. The next one shows the kitchen, I seem to recall. Yeah, that's the kitchen. You can see the stove on the left. And, you couldn't go into the kitchen. So catastrophic state of squalor. So Mrs. H did not want to move into age residential care at all. Right? She was absolutely clear about that. And just listening to her talk, you'd think she had capacity because she was so definite in what she said. In fact, she'd cower you into sort of running away from the argument, to be honest, except that she kept calling and people were sure she would die in a bad way. What does she understand about this? Does she understand what the doctors are worried about? The conversation I had with her was just to say, so this is what people are saying. This is what the doctor's saying. Do you know who the doctor is? And what has the doctor told you, the geriatrician in this case, told you about your situation? Do you know you have medical conditions? Can you say the diagnosis or something that tells me, there's a diabetes problem, there's a stroke problem, you can't see too well that you keep falling. Can you understand that the biggest thing people are concerned about is that you could fall and you wouldn't be able to get help, and that if that were to happen, that you could die, and it wouldn't be very pleasant. It wouldn't just be dying in your bed in your sleep. You'd be on the floor, dehydrated, a day or two later, maybe in pain. That even if you go home, you'd need support. It's possible, but you need to have people come in. There'll be various things they have to do. Could she, in a sense, say, well, I really value my independence, I really value my privacy, because that was one of her values. But I'm staring down the barrel of age residential care. So balancing these things, a little bit of intrusion in my privacy at home, which does give me the ability to tell the person to go away if I get sick of it on any given day, but generally I have accepted, is far better than the other option. And she now, obviously part of the reason for making this point is that I'm also doing the same thing, and you've got to be aware of your own process. I'm meant to be listening. What you're meant to be doing is just watching how the patient is balancing these things off. But you yourself will be drawn into a value judgment about, look, it's pretty obvious, you know, just accept a little bit of help and you'll be fine. It makes no sense that you don't accept some help. But it is the privacy value that is important to her. Can she retain the information? I've already touched on that. She did actually retain information. I saw her the next day. I did the assessment over 2 appointments. That may sound like a luxury in general practice, but if you don't have to do this in an emergency, you could see the person twice. Or, just to get back to the nurse practitioner thing, an idea that crosses my mind, because I did a lot of work in rest homes as a psychogeriatrician, is you could do your assessment based on what the person tells you, and you could delegate to, you know, a nurse, a registered nurse, you know, just ask the same things tomorrow, just see what that's, and let me know. So you get a second go at it via a nurse who's a registered health professional and can give you the report of what and that would be, I think, valuable information in terms of putting together an assessment of capacity. The using and weighing, I think I've covered in a way. There's no specific question you ask for that, but what you're looking at is the person taking this information and going through some kind of process of thinking about it, that they can say to you, yeah, well, that's important to me, but I've always been somebody who, you know, likes this special kind of food. I've always liked my own independence. People know this about me. My daughter will tell you that, or whatever, and that's why this is important to me. And I'm just struggling to see a reason to change that point of view now. So there's always background. You know, when you have somebody who's really difficult to get them to change their mind, or there's always background information. And this lady came from overseas. She wasn't born and bred New Zealander, and so she had a set of medical ideas that were probably more common in her culture than in sort of Pākehā New Zealand culture. There was a history of trauma. She lived through the war, the Second World War, so a lot of dislocation and trauma, which I think played a part. And it's difficult when a person's developing dementia to know exactly what part it plays, but that sort of brittle emotional dysregulation type of presentation that you'll be familiar with. There were relationship issues. So I think a daughter had lived with her at home for a while and then moved out, and it was an acrimonious parting, and there was no chance of getting family involved in this particular instance. And she'd fallen out with the neighbours. So although they were concerned, I think they're just good people. They just felt they couldn't ignore her, but it wasn't a comfortable neighbourly relationship. GP was really at a loss. I mean, I talked to the GP, and he said, geez, she listens to me if she wants to. I don't know if she ever does, really. The diet was unusual. It was not only vegetarian, but it had to be not cooked above a certain temperature, which gave rise to concerns about, you know, gastro and things like that, nutrients. And then she became a bit paranoid. You know, thought the hospital started in cahoots with the residential care providers to make extra money. I mean, these are the nurses she's talking about, not the geriatrician, well, not only the geriatrician. So the question about can delusions be, you know, do you factor them in? Well, there you do, really. You think, well, she believes stuff that's a paranoid sort of idea that's affecting her ability to weigh this information. Well, she thinks that. She had been very independent and proud of that, so that was a value. She thought the chance of her falling again, so she'd fallen a number of times, 3 times this year, or 3 admissions this year, and 1 bad fall previously, and I think others as well. She thought the chance of another fall was the same as the chance of an asteroid hitting the Earth, and she wouldn't discuss it anymore with her. That's what she said. I quote her. I'll say that. She thought, in fact, the first fall, the bad fall, was caused by shock waves from an earthquake in Denham. No damage to the house, but it caused her to fall over. And she refused to have a personal alarm because it would emit electromagnetic waves. I think she thought it was magnetic waves. And I said to her, look, it's off all the time until you turn it on and press the button. So mainly it doesn't. It's only just for a burst when you're in trouble, and she wouldn't have a bar of it. So you couldn't get her to shift her position at all. Thanks, John. So in terms of supported care, I mean, there was support, and I've got a slide on this. I mean, the social worker and the occupational therapist had gone to a lot of trouble to devise a support package. It always fell down around her mistrust of the caregivers. She had previously sacked caregivers. It wasn't really possible to be confident that an arrangement would work. You'd need an order for it to work. You couldn't. If she agreed to it, she'd change her mind. So that had happened and been done and it failed. I just gave some diagnostic stuff there just so you have more of the scenario, but it's not terribly important. We made the point. The staying at home was based on an OT assessment. You need that sort of information for this movement to age residential care often. I'm not sure how you do it in general practice, but a needs assessment seems essential. There was a question about financial capacity, which we didn't go into. That wasn't covered, except for paying for rest home care. So the assessment that I had to do, at the end, what was my question? My question was, can she decide to go into age residential care or not? Or alternatively, can she decide to accept a suitable package of care at home? What would supported decision-making look like? How would that in practice look? Well, it could be something like her having to have regular health and welfare checks. So she lived alone. Could somebody get into the house, once a day, 5 days a week at least, and maybe once over the weekend, I'm not sure. Some sort of personal alarm, I think, would have reassured other people. Home help, she couldn't keep up with the house. It wasn't like the pictures, but it wasn't great. She was fussy about her shopping. She wasn't really mobile enough to do her shopping alone anymore, and that was a problem. Very thin lady. She was tiny, absolutely tiny. She needed to have some sort of reviews by her GP, so she'd need to go along. Medication would need to be blister packed, delivered, and then checked that she was taking it. And ideally, all of this needed to be looked at a later date. So, in fact, when I did present my capacity to the judge repeated the assessment, and thank goodness she answered all the questions to the judge in the same way she answered them to me. So I didn't look stupid. I was worried about that. So the judge got the same answers. And then the judge said to the lawyer, look, just can't you persuade her to accept something, just be a bit reasonable? And so this was kind of discussed in a superficial way in the court. And there was a break given for the GP, for the lawyer to talk to about, can you meet us halfway? But consistent with the idea that she couldn't, she was rigid, she couldn't use away information, she couldn't share to do, or perhaps really didn't understand the seriousness of the situation. She didn't change her view at all. So she said the falls didn't happen the way the medics said. There's no risk of recurrence. There were no issues with her mind or personal care. Wouldn't allow any sort of package of care or care arrangement, and she couldn't imagine a scenario in which she would change her view. So the judge said, decided she lacked capacity and noted one of the factors was a rigidity of thinking. So the phrase he used. So I guess just to summarize, I mean, what you're doing is you've got a patient in front of you where you've started off with a presumption of capacity. The capacity is specific for a decision, so you have a decision that's got to be made, and for some reason the patient can't make the decision, and so you've got some red flags. You do the assessment, you recognise the capacity may fluctuate over time, but with dementia you're expecting it actually to fluctuate downwards, really. I want to make the point here, I haven't made the point up to now, but I think I should make it. You can't do an MNSC or a MOCA or a mini Addenbrooke's and say that's a test of capacity. That's a test of cognition, and it's useful because if you're going to have a report saying the person has dementia, it's really handy to be able to say, look, they scored this on a standardized test. It is a handy thing to do. But the test of capacity is, can they make the decision? That's the test of capacity. And if they can't, why can't they? What are the problems in making the decision? So that's the test you do for capacity, not the MOCA. It's really important, I think, that a medical person is involved in an older person. I'm a psychogeriatrician, so my interest is in that sort of group. I think psychologists have come to the fore with assessing capacity in people with ID, young and strong and physically well, largely. But in older people, the question of some sort of medical condition that could be treated and improved, or medication that could be changed that might be impairing capacity and they could get better is important. And I think it needs a nurse practitioner or doctor to put their mind to that possibility. I've mentioned the red flags. Undue influence is something you get asked about, and that's really in that a separate talk in a way, but something to worry about where money is involved, basically, and possibly where I think somebody asked about end of life decisions. Can caregiver decide if somebody should end their life or their life should be ended. I mean, that's an area where I think people are worried that undue influence may play a part. Again, outside the scope of talking tonight, because it's a different piece of law, but certainly, undue influence is a worthwhile thing to have in your mind. So a diagnosis doesn't automatically mean incapacity. John's talked about that. I think Alison knows it as well. The person is entitled to make an unwise decision. So the person can take risks, in other words, if they know what the risks are. And we can't really take risks for them. So we're naturally much more conservative, which is where we might do harm. But if they know what they're doing, they're entitled to take risks. I think I've stressed enough the need for information before you set out an capacity assessment. And the 3 steps in the assessment are, the getting the information, seeing the person and asking the questions, and then, separately having time to think about whether you feel you've come to a conclusion or whether you need a bit more information. So you have to be able to say, look, I'm not going to make a decision at the end of this 15-minute consultation. I'm going to see what I find about this decision, and then I might need some more afterwards. So that's my part of the talk. It's probably best to open for questions now.
So on our website, we have a link to the assessment of mental capacity and the toolkit and other resources for those of you out there that are wanting to look further. Now, we just have time for just a few questions before we wrap up tonight, and we'll centre these initially around EPOA, if that's okay. So there's a question from nurse practitioners who form a really core base of our listeners out there. And it's just a question of whether or not they are able to sign off the activation of EPOAs. Might be a question for you, Alison.
Well, as I was saying before, EPOAs, or enduring power of attorney, all fit under the umbrella of the PPPR Act.
Mm-hmm.
There was, for activating EPOAs, there were a set of forms that could be used, but the law has been fiddled with, as it were, and so they took away those forms. But leaving that aside, it seems to me that there is no reason why a nurse practitioner can't sign off an EPOA in terms of activating it. And one of the things that we've done with our book is actually to recreate similar forms that can be used, which are in the back of our book. We've also actually one of the changes to the law on EPOAs is to have where the lawyer, when you make an EPOA, the lawyer has to certify that they've got a reasonable belief that the person has capacity. So now there's also a chance that a GP or a nurse practitioner may be asked to give an opinion of capacity as an assurance that the lawyer who's helping the person make the EPOA can confirm that they have capacity. So that's a kind of a new development. And again, we've created forms for opinions of capacity, as well as opinions or medical certificates of incapacity. So, but getting back to the question, I think, yes, anyone that can complete a capacity assessment and justify the opinion should be able to certify it.
Great. And what do we do if there are conflicting views between health professionals with regards to capacity assessment?
Oh, well, that's probably not that unusual. And that's the whole point, actually, about capacity assessments, which is that one assessor may come to one conclusion and another assessor may come to another conclusion. And if it is a case that goes to court, for example, as to whether or not the person had capacity to make a will or an EPOA or whatever it is, it's actually the judge who will decide. So it is a legal decision. And some of the cases you'll see that the judges have actually rejected opinions where a psychiatrist might have said this person lacks capacity. But of course, so a number of scenarios can unfold. But I think just to reassure, GPs and nurse practitioners that it is not common for capacity assessments to be contested in the court setting. certainly not in New Zealand. So, but it is still about making your case in terms of, justifying your opinion, even if it's different from somebody else's opinion.
Okay, thank you. Now, can a person activate EPOA while they're still technically competent because they are aware of their function that is deteriorating slowly?
Well, I suppose there's, not really, no. I mean, the point is that the very important point is that the person has capacity when they make the EPOA.
Mm-hmm.
And as I say, now the rules around making enduring powers of attorney, and people might have seen these rather long forms and information sheets that go with them. But really, there has to be some certainty that at that point in time, the person does have capacity. So, I mean, the whole point of them appointing an attorney is appointing someone to trust who, when they do lack capacity and the EPOA is activated, then that person will be making the decision. So I suppose you can't really preempt it. It gets a little bit complicated when a person then regains capacity and you're wanting to deactivate the EPOA. But that's probably subject of a slightly longer talk. But I mean, the point about this is that it's not a fine art in the sense, and it's difficult because the law is concerned with capacity at a point in time. And so that can change.
Okay, and often as practitioners, we sometimes find ourselves looking after families, so not just the individual, but people around the person that we may be assessing capacity. If we are aware that an activated EPOA isn't acting in what we believe the best interests of our patient, is there anything that can be done around that?
That's quite a big question.
That's probably not the right one for the last one of the evening.
I could just hand over to John, because as a court-appointed lawyer, of course, representing a person where there's an application before the court, and it's the court-appointed lawyer's job to find their way through the conflict that might emerge in a family as to who should be the decision maker and whether this person does lack capacity, whether there's undue influence operating, all of those things. So in a lot of ways, the GP is in a sort of a similar sort of setting in terms of finding their way through this. But there is also a very important point for GPs, I think, and John might wish to add to this, but where there is conflict of interest, because often, of course, GPs may act for an entire family, or a nurse practitioner, is familiar with the entire family. So, John, do you want to just add a bit to that? Because I think it is important to identify who your patient is in this context and how you deal with that conflict.
Well, I'm not sure I can add much to the point that you've just made then, which is figuring out who the patient is probably the kind of key thing. But I think these things can become nightmarishly complicated. Alison, so is the process, if someone's concerned that a EPOA isn't acting in someone's best interests, it's back to court, is it? Is there a clear route for that?
Yeah. No, so there is an ability to take them back to court, particularly if the attorney is said to be not acting in the person's best interests. The problem is the way the law has developed in New Zealand is that's quite complicated, and it doesn't actually, that ability to go back to court is not often used. But what tends to happen is that then someone might go in and actually ask for a court order. So they will revoke or remove the enduring power of attorney, and then there'll be a court order for a welfare guardian or a property manager. So that's where the court does have some oversight. So yes, so if there are concerns, that there is a route there to the court, to the family court.
So this is probably another one of those instances where there's a process within the PPPR Act where we need to look at it and improve the law around this. This seems like a problem here to me.
Okay, well, thank you so much everyone for joining us tonight, John, Greg and Alison, for speaking upon this really complicated and tricky subject. It's lovely to have that sort of framework that practitioners like myself and those in the audience can begin to gain confidence in venturing out into this space, which for a lot of us is uncommon and untread ground. And hopefully everyone can rest easy now and enjoy the rest of the evening. So thank you again once everyone, and good night.